our two speakers for tonight. Starting the webinar is Dr. Stephanie Wu. She is a fellow of the American Academy of Optometry, the treasurer of the Scleral Lens Education Society, and she recently became a partner in her private practice in Arizona. Our second speaker is Dr. Mindy Toabe. She is a fellow in the American Academy of Optometry, the secretary of the Scleral Lens Education Society, and a clinical senior instructor at Case Western Reserve University. Their lecture tonight is titled Scleral Lens Billing and Coding. Just a few housekeeping things to go over. So we're going to start very shortly. Feel free to ask any questions using the control panel. If you want to submit a test question, just type in your state and send that over to me. I'll try to answer questions that I can, and then we'll also have two question sections during the actual webinar. If you do lose the webinar screen, just look down at the bottom of your taskbar for the little blue flower icon. Click on the blue flower and your screen should pop up. And of course, if you run into any other technical issues, feel free to call this phone number right here and we'll try to get you reconnected. And I'm going to let these two ladies take it away.
Thank you, Karen, for those nice introductions. My name is Dr. Stephanie Wu, and I will be heading off the webinar tonight. But of course, we want to say thanks to our sponsors. Our sponsors are a huge reason that the Scleral Lens Society even exists, and without their support, we wouldn't be able to do these cool free webinars. So I'd like to start with our diamond sponsors. Our oldest diamond sponsor is Bausch & Lomb Specialty Vision Products, who acquired Alden Optical, and they are the creators of the Zen lens, which is a comprehensive 24-lens diagnostic set with prolate and oblate designs to fit a wide range of corneal shapes and sizes. Our other diamond sponsor is Art Optical, who creates the Ample Eye, which is a 4-zone 16.5 millimeter scleral lens that employs spline science technology to connect and smooth lens junctions, which helps fit patients with regular and irregular corneas. We'd also like to thank our platinum sponsors, starting with Blanchard Contact Lens. Blanchard Contact Lens creates the MSD and One Fit scleral lens series. AccuLens creates the Maxim, Comfort SL, and Easy Fit scleral lenses. Alden Optical creates the Zen lens. Contimac is a leader in the development of specialist polymers to create the scleral lens buttons. Essilor Contacts creates the Perimeter, Jupiter, and ProLook scleral lenses. Minicon is a pioneer manufacturer of contact lenses and contact lens care products. Paragon Vision Sciences creates the Normalize scleral lens. Visionary Optics creates the Jupiter, Europa, and Elara scleral lenses. And XL Contacts creates the Atlantis scleral lens. Of course, we would like to thank our silver and bronze sponsors as well. And without their support, we wouldn't be able to do these webinars, our newsletters, and some of our continuing education programs that we do around the United States. So thank you so much to our sponsors for all of their support of the Scleral Lens Society. Let's jump right into billing and coding. And what is the right answer? Well, billing and coding is a leading source of frustration for not only practitioners, but patients as well. A lot of times we're trying to figure out how to get paid, and we have to pay in a timely manner. We have to submit these codes. We have to do so many things correctly in order to get reimbursed properly. And sometimes this can take weeks, months, years, or possibly we never get reimbursed for our services, and it's very, very frustrating. Reimbursement rates can vary drastically between insurance carriers. And it's really difficult because you can bill the same CPT code to different insurance carriers, and some of them require modifiers designating that the contact lens is medically necessary. Others will deny your claim if you have that modifier. So it is frustrating because we have to look at each insurance company differently, and it's of course different based on where you live as well. I like to think of billing and coding the same way as taxes and accountants. If you took your taxes to different accountants, they would interpret the information differently, even though you gave them the exact same documents. And it's sometimes the same way with billing and coding. I will ask one expert or even a billing and coding staff member of the insurance company that I'm dealing with, and they will tell me to code things one way, and then if it gets denied, I talk to somebody else, and they tell me to code it a different way. So it's frustrating because even though it seems like it should be a straightforward answer, a lot of times it's different and you get different answers. So it is a frustrating topic. I'd like to now go through the economics of specialty contacts. Most vision insurances actually reimburse very well for specialty lens fittings and devices. Specialty contact lenses can include the following. It can actually include standard soft lenses, custom soft lenses, corneal gas permeable lenses, hybrid lenses, and scleral lenses. So it doesn't have to just be a gas permeable lens to bill through vision insurance. You can actually bill some of your standard soft lenses and custom soft lenses too, depending on the diagnosis and the condition that you're managing. In conclusion, specialty lenses can be a profit source within your practice and a good source of revenue. Medical insurances can be more difficult to obtain appropriate reimbursement, and Mindy's going to be talking about this in a little bit. And if you accept many different types of medical insurance, it can become tedious and time-consuming because you have to figure out your patient's benefits, and then you have to bill each lens fitting and the lenses a bit differently between the different carriers. Some practices bill each visit to the insurance, and Mindy's going to talk more about this later. People are always asking me questions on how much to charge for scleral lens fittings and the lenses themselves. But the fitting fees really range from low to high, and that really does depend on the practitioner and the practice. You have to really think about the amount of time that's needed at each visit to develop a fee schedule. Think about the amount of time that it takes for you to do that contact lens consultation. How long is it taking you to do the contact lens fitting? Is it going to just be you as the doctor fitting the contacts, or is it going to be staff members that help you? How much doctor time is actually used up during the fitting? Also, the contact lens dispense and training. Is this all performed by the doctor? In my practice, when I first joined, none of the staff members knew anything about these types of contacts, so I had to spend the entire time with the patient myself. So that costs a lot of doctor time. But now I have staff that are trained, and they can help me with some of this contact lens training. They can help me with some of the testing and things of that nature. And same thing for follow-ups. If you as a doctor are taking the time yourself to see them, that might cost a little bit more instead of having staff help you. Not only do you need to consider the time it takes, but you need to think about the supplies and equipment that you are using during each visit. So during the consult, you might be using special equipment like topographers, anterior segment cameras, OCTs, things like that. For the actual fitting, you'll need some plungers or other insertion devices, non-preserved saline, your sodium fluorescein, and other things that you're using. For the dispense, you'll need special equipment and other testing if you have it. The contact lens training, are you going to give them a kit that includes supplies? If you are, what is the cost of that little kit that you're giving to the patient? And then all of the follow-up care. What equipment are you using at the follow-up care? What supplies? And how much time is this taking up? So you really have to kind of put both of these together. So considering the amount of time that the patient is allotted, and the amount of doctor time with the patient, along with your cost of supplies and equipment, then you can develop a fee schedule that's aligned with your chair time costs. There is something that is free. It's from the GPLI. GPLI.info is the website address. But if you go down to resources, you can see there this little drop-down menu shows up, and you can click on that professional fee calculator. And this will show up. It's not the entire questionnaire, but just a portion of it. But this can kind of help you come up with a projected chair time cost and what your fees are worth. So this was really helpful for me when I first started practicing, because I didn't really know anything about fees or how to collect and things like that. So we kind of had to use some of the information that the practice I was joining, this information, and kind of put it in, and it just kind of came up with a rough number. So if you don't have any idea of where to start, you can always check this out as a free resource from GPLI. Vision insurances will usually incorporate the lens fitting and the lenses into one lump sum, and that does include the lens fitting, the lens dispense, and all follow-ups within a certain time period, along with the scleral lenses. And that differs from medical insurance, which will pay for the fitting as one charge, the lenses for one charge, and each follow-up and every single time you see that patient, they're billed at separate charges, which Mindy's going to go over in great detail later. I just wanted to go over a few common codes and descriptions, because you might see these as options on the paper charts that you're using for submissions, or some of the drop-downs on the online forms. So 92310, that is a corneal lens, and that does include the fitting for both eyes. 92072 is a fitting of contact lens for keratoconus, and there is some ambiguity with this code, because you see that area where it says initial fitting. Well, a lot of people are wondering, well, is it the initial fitting like they've never been diagnosed with keratoconus before and it's the first time they've ever been fit? Or what if you are seeing the patient and they've already been fit with lenses for keratoconus? Would you still use that code? A lot of people have varying opinions on this. Personally, I use it for my patients that I'm seeing for the first time and I'm fitting for the first time that have keratoconus. There might be other varying opinions out there, but just from what I've gathered from talking to a lot of different billing specialists and insurance companies, that's the code they prefer that I use when I fit that keratoconus patient for the first time. 92313 is a corneal scleral lens code. It is also a bilateral code. This is one that you will use a lot with vision insurance, because it's the only option for scleral lenses, especially if it's a patient that does not have keratoconus. So even though you might be using a full scleral lens, not technically a corneal scleral lens where the lens is bearing on the cornea, you will still want to use this code. And then 92312 is for fitting a corneal lens for aphakia. So you wouldn't use the top or bottom codes for patients with scleral lenses. You would really only use the 92072, and that's for a patient with keratoconus, and then the 92313, which is fitting a scleral lens for a patient that does not have keratoconus. The other two codes are for corneal lenses, so ones that are actually touching the cornea. This is directly from GPLI, and these are the HCPCS codes for the medically necessary contact lenses, your V codes. And just wanted to point out the V2531, which is the fourth from the bottom there, is contact lens, gas permeable, scleral, and that is per lens. So if you have one per eye, you will designate that as right or left when you are billing that to insurance. Scleral cover shell V2627 is also a lens type that you might use depending on the diagnosis. Here's just an example for vision insurance, and I just use these numbers for ease of math. Let's say you do a scleral lens fit for both eyes. You're going to use that 92313 code. Let's say your fee is $200 for that. Then you will bill the scleral lens device V2531 and then the RT designating for the right eye, and let's say you're charging $400 for that. And then you would itemize the next line as scleral lens device V2531 LT, designating that's for the left eye, and that will also be $400. So you will bill $1,000, so that's the total of your fitting and the lenses, as one lump sum for all of your services and lenses, which will be different than medical. Most vision insurances will reimburse for medically necessary contact lenses, but you have to remember that similar to glasses or contacts, they will cover one benefit and not the other. So if a patient has already used their glasses benefits or contact lens benefits for the year, they will not be eligible for medically necessary contacts. So you have to consider that if the patient's coming in and they are wanting to use their vision insurance for medically necessary contacts, you need to make sure they have not used that benefit in that period for glasses or other contacts. If you find a patient that has VSP and you think they are a good candidate, just call VSP, or you can go online to find out if they are eligible for medically necessary contacts. If the patient is eligible, they will give you an authorization number, and they will also tell you what that material copay is. After you do the contact lens fitting, you will just log on to eyefinity.com and you will input all the information. And I have that step-by-step on a previous webinar that you can watch, so I won't go over that this time, but if you want to know step-by-step exactly how to input everything, that is on another webinar. VSP will pay for the type of contact lens fitting and the type of contact lens. As a general rule, VSP does pay higher for hybrid lenses and scleral lens fittings, and then also those lenses compared to other modalities. And something else unique about VSP is they pay according to the diagnosis. They will pay more for what they determine to be a more severe diagnosis. If you bill with the code 92072, 92313, 92312, or 92313, which are some of the codes that we went through before, with these diagnosis codes, this will pay you at the visually necessary contact lens specialty maximum. And these are just a few common ones that I just kind of copied and pasted. So you can see, of course, keratoconus is on there, dystrophy, corneal ectasia, corneal scars, corneal transplant, things like that. These are all things that VSP considers to be a very severe corneal condition, and thus they will pay higher. This was information from 2015, so of course everybody's will be different depending on the state that you live. But you can see the V2531, the maximum that they will that VSP will reimburse you is $2,300. You can see that's the third from the bottom there. But keep in mind that that is something that if you bill above that, they will reimburse you. So if your usual and customary fees are only $1,000, then that is what VSP will pay you. This is not a fee that they will automatically pay. They will pay up to that fee depending on your usual and customary fees. For iMed, if you think a patient may be a good candidate for them, go ahead and just call iMed directly, ask if they are eligible, and they will also give you an authorization number. Within the past few months, they've actually kind of gone away with the authorization numbers, and you just fill out the medically necessary form. The form is only one page. You fill it out, and then you fax it back to iMed. This is what that form looks like. You can get this right off of the iMed website, and you can see at the top it says medically necessary contact lens claim form. You just fill out the member's information in some of those top boxes, and then below where the big boxes are, you will check off what the patient condition is, and it will tell you how much the iMed will reimburse you. I just kind of blew this up here so you can see at the very top it says medically necessary codes, and that includes contact lens evaluation, fit, follow-up, and materials. So here's another example of a vision insurance that is covering everything in one lump sum. And the two I would just kind of like to point out is the keratoconus, which is kind of in the middle to the right there. You can see it's divided into two boxes. Keratoconus as mild or moderate will pay at a lower rate. You can see it will pay up to $1,200 for services and materials. And then keratoconus that is advanced, or they've got ectasia, they will pay at a higher rate up to $2,500 for services and materials. Now, there is no real literature out there in the iMed manual that says if you have this type of patient, they qualify as mild, moderate versus advanced or severe. So a lot of practitioners will ask me, well, how do I know if my patient is mild, or are they moderate, or are they advanced? And the answer is it's really up to you as the doctor until they publish some sort of data that says, you know, the topography has to be X, or they have to have stria, or whatever diagnoses they come up with. We just kind of have to use our best judgment at this point. The other one to the very right is vision improvement, and this is when keratoconus is absent. So this would be for a patient that has corneal transplant, maybe they have a corneal scar, herpes, let's see, really any condition where the vision can be improved by 2 lines on the visual acuity chart compared to standard glasses and contacts. So this is often a code I use for my post-refractive surgery patients, like post-LASIK ectasia or RK scarring, things like that, where their vision is not very good with glasses, but with a gas-permeable lens, their vision improves dramatically. And Karen, do you have any questions for me on billing vision insurance? I'm sorry, I'm not hearing anything. Karen, if you're trying to talk, I don't hear anything.
Oh, sorry about that. Hello?
Oh, it's perfect. There you go.
Oh, got it. So what I've encountered is that with VSP, I'm seeing a lot of patients that have Sjogren's syndrome, and they'll come in with VSP, and it seems like a very medical reason to get scleral lenses, but I'm not able to get them coverage through their insurance. Have you had any luck with that?
Right, so Sjogren's disease is considered a medical condition, so you have to think of vision insurance is usually going to cover contact lenses that the primary purpose is for their vision. So like keratoconus, the reason they need these contacts is to get better vision, whereas Sjogren's patients or patients with severe dry eye or ocular surface disease, that is considered more of a medical necessity, and thus you would use their medical insurance to cover something like that. That's a really good question, and most vision insurances will not cover something that is considered medical like that.
Next question. When you're billing VSP for a fitting, do you, so I guess, when do you consider the fitting period over in your office?
That's also a good question, because there's really no guidelines in the VSP manual that says you have to follow the patient for X number of days. In my office, I do 90 days. Sometimes I have a very severe case, like a very fragile graft, and I have to monitor them a little bit more, so I might extend that to 6 months. But I think it just depends on the patient and the case and kind of what the practitioner feels comfortable with for their own follow-up period, but most of my patients are 90 days.
90 days. And then so for that 90-day period, you just do like no charge follow-ups, and then after that you either start billing their medical or something else.
Exactly. So if within that 90 period, if they came in every single day, I would just never charge VSP because or iMed or whoever I used, because I'm just considering that as in that quote-unquote global period. But then after that 90 days, I will either bill their medical insurance depending on the complaint, or it will be at a cash price depending on what the reason for their visit is.
One of our participants is wondering, when do you submit the claim, before, during, or after the fitting?
Okay, that's a great question. So I've gotten confirmation from the insurances that you should bill for everything after the fit is complete. So after they've done their dispense and probably after you've done a few follow-ups with them, because I've made the mistake where I've billed it on the day of their fitting because I thought, well, I did the fitting and I ordered the lenses and blah, blah, blah. So I submitted that, and then it ended up that the patient was a non-adapt, and then they ended up not going with scleral lenses, so I had to call the insurance to find out what we do in that case, and they said, well, you're not supposed to really bill it to us until everything is complete, so you can avoid that situation.
Just as a side note, I do exactly what Stephanie does, and I will bill after the fitting's complete. But just keep in mind, your VSP authorizations actually do expire if you don't submit for it, and they'll expire within the month within 1 month after you pull the authorization. I have another participant who so kindly mentioned that iMed actually has a list of branded contact lenses that they consider to be necessary for advanced keratoconus, and that is how they qualify the difference in staging for keratoconus. So thank you for that. And
oh, thank you.
And one participant was wondering if you could explain the difference between a 92012 and a 92313 one more time.
So the sorry, let me go back a second. Okay, so the 92312, that is a corneal lens only if the patient is aphakic, so somebody that went through cataract surgery or whatever and has no lens. Whereas 92310, that person has their natural crystalline lens and you're fitting a corneal lens. So let's say you're fitting a GP lens, you would most likely use the 92310 code. But if they are aphakic, that is the only way you would ever bill the 92312 code.
And then one other person was asking for, this might be for Mindy's section, for private insurances, are you creating 2 different lines for the fitting of each eye?
So I will let Mindy answer that maybe in her next section, if she could go through her slides, and then maybe she can touch on that.
Okay, some very good questions so far. I guess for now we'll just move on.
Great. Thank you, Karen. And Mindy, I will take it, you can take it over from here.
Okay, thank you very much, Karen and Stephanie. As a reminder, specific guidelines for billing and coding vary by state, insurance plan, and type of practice. As a practitioner, it's your responsibility to become familiar with your state insurance plans. Next. Next. This section of the billing and coding webinar will focus on medically necessary contact lens fitting in the context of hospital-based management billing for government-related insurance plans, such as Medicaid or CareSource. Medicare does not cover medically necessary contact lens fitting or lenses. And we use the term medically necessary because a scleral lens falls under the definition of medically necessary, and insurance providers use this term for coding. Medically necessary contact lens fitting and lenses can only be billed one time to the insurance company after prior authorization for this service has been approved by the insurance company. An advanced beneficiary notice of non-coverage, or an ABN, is a standardized notice that's issued to a patient before providing services. So an ABN should be issued when you believe insurance may not pay for this service. During your visit with your patients, it's important to set expectations. Inform the patient that the process may take up to 3 months with visits every 2 weeks. Why 3 months? Because most labs provide a warranty for lenses for 90 days, and the goal is to complete your fit before the warranty expires to maintain a profit. There is no correct coding initiatives for testing that's commonly performed during medical contact lens visits. In other words, you can bill for these codes at any visit together or separate, but keep in mind that the multiple procedure payment reduction also applies to these codes. The MPPR reduces the reimbursement for a second test performed on the same day of service. Next. Prior authorization has to be completed prior to billing for medically necessary contact lens fitting and lenses. And prior authorization has to be completed in order to be paid for services rendered to the patient. So when submitting for prior authorization, include the lens design, which would be the scleral lens code and the matching fitting code, which would be a keratoconus code. We can also use an ocular surface disease code or the corneal scleral contact lens fitting code. So if you're working in a hospital or a large practice, there may be a billing and coding specialist that can guide you on appropriate codes. Next. The first visit for your scleral lens patient should be a consultation visit if this patient was referred by another practitioner. The goal of the first visit is to determine the best visual acuity with a medical contact lens and to set expectations. If this patient was not referred, then use a comprehensive exam code if you're dilating the patient's eye that day, or a limited exam code without dilation. The requirements for a consultation visit of low severity would include 1 review of system, that would be the eye, 1 social, I use smoking, 3 history of present illnesses. It could be location, such as the eye, quality, which you could say ask about blurred vision or visual distortion or halos, severity, duration, and I'll ask if the condition began in adolescence or in adulthood, and timing. After completing the history, proceed with the requirements for an established eye exam, including visual acuity, extraocular muscles, confrontation field, pupils, eye pressure, and slit lamp exam. Proceed with testing, such as topography, pachymetry, or photos, depending on the eye disease being managed. And a letter to the referring doctor is recommended with a consultation billing code. Next. Ideally, between the first and second visit, prior authorization should be completed and approval should be obtained and scleral lenses should be ordered. The timing for this is about 3 to 4 weeks between the first and second visit. So the second visit is a medical visit to assess the health of the eye, especially the anterior segment in relationship to the medical contact lenses. So an established patient code is used at this visit. Include the chief concern, visual acuity, pupils, extraocular muscles, confrontation field, and slit lamp exam. Once the established patient visit is completed, continue with testing. An ocular An OCT of the anterior segment could be performed at this time, or other testing. At the second visit, after you have done your established patient, you've done your testing, and you've completed these requirements for billing, then proceed with the scleral lens fitting exam. Perform insertion and removal training if the lens is fitting well, and bill the fitting and material codes at that visit. Explain the care systems, perform insertion and removal training, and then schedule the follow-up visit. Next. So all of us are excited when we fit a patient in 3 visits. The 3rd visit is billed as another established patient visit, and a follow-up visit is scheduled. What do you do when the patient goes home with the lens and there's a problem and the lens needs to be adjusted? Use the established patient visit. So let's look at the definition of an established patient visit. It includes an evaluation of an existing condition complicated with a new problem not necessarily related to the primary diagnosis. Meaning that we would code for the existing condition and add a code for the new problem. The existing condition is the keratoconus that we are working with, or the ocular surface disease we're working with, or the other eye condition you're working with. What is the new problem? It's the sign that you are seeing on the cornea, or the symptom the patient is experiencing with the scleral lens. For example, you could have a patient that's experiencing decreased vision with the new lens resulting in a power change of the lens. The existing condition is keratoconus, and the new problem is blurred vision. A patient could be experiencing halos, which could be due to scleral toricity, and you could change the lens design accordingly. Superficial punctate keratitis would be a sign that you would observe if the lens is too flat and rubbing against the cornea. Next. For any additional visits, complete the established patient visit first. Include your sign and symptom code to demonstrate the reason for the visit. Then perform the scleral lens exam, complete testing if needed, and review care systems as needed. Next. Let's go over fitting codes used for medical contact lens visits pertaining to scleral lenses. So there are 3 fitting codes for scleral lenses. Keratoconus, which Stephanie talked about earlier, 92072. Ocular surface disease, 92071. And corneoscleral contact lens fitting, 92313 for everything else. There's also a code we can use if we are making a major modification to the lens design. That means changing from a corneal lens to a scleral lens, or a hybrid lens to a scleral lens, and so on. 92325. This code does not apply to a power change or a modification of the existing lens. And there is another code for ordering a duplicate lens, 92326. Next. There are specific material codes for lens designs. V2531, which Stephanie mentioned, is the code for a scleral lens. There is also a code for cleaning and polishing a lens in office, the V2624. For non-scleral lenses, use the same code with different pricing. So we use the V2599 for a hybrid lens with a different price, or V2599 for a soft cone of a different price, etc. Next. So I talked about testing during these exam visits. Remember that we are evaluating and treating a patient with a corneal eye disease. Each test performed requires the results noted in the chart to demonstrate why the test was performed. Pachymetry 76514 is a test performed to measure corneal thickness for keratoconus and other corneal degenerations and dystrophies. Pachymetry can also be used to check for corneal edema during scleral lens wear, especially for patients who've had a corneal transplant. Ideally, pachymetry measurements should be made before scleral lens wear and again during scleral lens wear if corneal edema is suspected. Next. Topography provides a picture of the anterior surface of the cornea, 92025. And topography can be completed at the initial visit to diagnose a corneal disease or to determine progression of the eye disease. In terms of scleral lens fitting, topography helps to demonstrate why a scleral lens was chosen rather than other lens modalities. And there are numerous codes that support scleral lens fitting and topography. Next. Anterior segment OCT is different from the other tests in that there is no statement by the Centers for Medicare and Medicaid Services in terms of national coverage determination and coverage provisions for anterior seg OCT. In other words, there are no specific diagnosis codes or reasons for performing this test. So we, as experienced anterior segment clinicians, have to explain in our notes why this test is being performed. What do we say? Remember that we are treating a patient for corneal eye disease and that we are performing an evaluation of the cornea with a contact lens, and that criteria is matched for decreasing the risk of corneal edema. So what is this criteria that we're quoting? Next. The criteria comes from a publication related to scleral lenses and hypoxia. This publication by Langis-Michaud predicts the risk of corneal hypoxia with scleral lenses and helps us to provide a reason for performing anterior segment OCT. State in your notes how the anterior segment OCT matches Michaud's criteria. Clinically speaking, use the highest decay material with the least amount of vault to decrease risk of hypoxia. Next. I'm just going to mention that external ocular photography is used to manage corneal eye disease, and make sure to include this test in your repertoire for treating corneal eye disease with scleral lenses. Keep in mind that ocular photography should be performed at one of the initial visits or early on to document the eye disease. Each year, you would take ocular photography again if the eye disease has progressed, because ocular photography is used to compare what you're looking at through the slit lamp to what you're seeing in the photo. Next. So let's go over an example of a patient that came into the hospital for a comprehensive eye exam and a soft contact lens fitting. She was wearing a toric soft contact lens with a manifest refraction of about -950, -550, with visual acuities of about 20/40 and 20/60. She had a history of Sjogren's syndrome with dry eye. So on this initial visit, I did not perform a consultation visit because she just came into my office to see me and was not referred by another practitioner. So I performed a comprehensive eye exam, a refraction. I inserted a punctal plug that needed to be replaced. And upon slit lamp exam, I observed corneal signs that could be from keratoconus. So I scheduled her for a medical contact lens evaluation with me at a separate visit during the medical contact lens clinic. At the second visit, I performed the limited eye exam established patient visit with testing. I continued with the medical contact lens fit for the scleral lens and performed the anterior seg OCT. Between the second and the third visit, prior authorization was submitted and approved, and a scleral lens was ordered for both eyes. At the third visit, I performed limited eye exam established patient visit and examined and dispensed the scleral lens with training. So I billed keratoconus with blurred vision, since that was the problem we were trying to solve at that visit. The patient called after dispense day and stated that her eye was getting red upon removal of the lens. So I ordered another lens with looser peripheral curves. At the fourth visit, she came in and I performed a limited eye exam established patient with the scleral lens exam. We inserted the new lens and I billed keratoconus with hyperemia. At the final visit, we billed another limited eye exam, established patient, hyperemia was resolved, the lens was fitting well, and then we set up a follow-up visit for 4 months. Next. So this is just a sample of the costs and a breakdown of exactly the codes that were used and the number of visits, and just to kind of give you some idea that you actually can make a profit with medical contact lens fitting in a hospital-based practice or in a large practice. Thank you for your time and attention. Any questions at this time?
Yes. So there seems to be a little bit of confusion over the initial setting of prices. And so some people are wondering, do you adjust your usual and customary fees for fitting and follow-up depending on how many visits are needed and how many lens adjustments are needed? Or do you usually use the same fees regardless? And this might be a question for both Mindy and Stephanie.
I think this would be a question for both of us, because in a very large practice or in a hospital, I have no control over pricing or billing. What we did was I sat down with the billing specialist. We went through exactly what I did for an eye examination for medical contact lenses, and we broke it down to these particular codes that I showed you earlier, with the different codes for the V codes for the lenses, and then those few codes for fitting. And those are the only codes that I use. I cannot change the pricing or make changes at all. So I had to go with a coding system that was flexible enough that regardless of which lens design that I use, I can use one of these codes, one of these V2599 codes, or the specific codes for a medically necessary corneal GP or a scleral lens code.
Yeah, and Mindy's right. You have to use the same price for whatever CPT code you are using. So that means if your price for a 99212 is $100, every single time you see a patient, no matter who they are, what the condition is, what insurance they have, whether they're cash pay, you have to legally charge that $100 every single time you use that code. You cannot alter them depending on the patient, depending on their insurance, depending on the complexity and things of that nature. You have to use the same code, and it has to be the same price all the time for every single patient.
This sounds like the GPLI tool, Stephanie, that you talked about that helps you really figure out exactly what you should set your price point at. This would be really handy for figuring that out.
Yeah, and I think it's
One
just a great little tool because it's free, and if you have no idea where to start, at least that can kind of give you a guideline of where to begin.
Mindy, when you are billing for pachymetry, topography, photography, have you run into any issues, like say you have to bill pachymetry like 3 times in 1 year to the medical insurance? Have you run into any problems with that?
I do bill it when I'm doing a scleral lens fit, especially on a patient that's had a corneal transplant or a patient that is at risk for corneal edema. I do bill the pachymetry at the initial visit, and I bill pachymetry at the initial visit for the keratoconus patients that I work with. And then I will bill again for pachymetry after the patient has been wearing the lenses to rule out any risk of corneal edema and just to make sure that there isn't some mild corneal edema occurring underneath that lens.
And how do you guys
And
decide
I'm honestly not sure about the billing, but I believe that it is going through because if there was an issue with it, the billing specialist would contact me about it.
That makes sense. How do you decide between using for your follow-up visits a 9.2 code versus a 9.9 code?
The 9.9 codes are the E&M codes, and the reason we went with the 9.2 established patient I codes is because with the higher E&M codes, we are not meeting all of the requirements that's needed to bill for that code. So the reimbursement would be lower than with the I code.
Got it. And then in one of the examples that you had presented, Mindy, on visit number 2, there's a 92012 visit with some testing. And they were just wondering, do you have to use a modifier 25 on the 92012?
Yes, you do use, you may be using a modifier for these codes, but in a hospital setting, the billing agents are actually including the modifiers, and I am not including it when I submit for the billing.
Got it. And then let's see. How do you, so at UCSF, I don't know if you guys do this much, but I find myself billing based on time quite a bit as well, and I put in like my little disclaimer in my chart. Do you ladies do that as well?
I do not do it based on time because I do not have a way to bill for it in the system that we have set up.
Okay. Well, one of our participants was just asking about billing based on time, and at UCSF I do use the 99 codes and I bill it based on time, and they're very specific. And when I do bill based on time, I just always put at the end of my chart, like, you know, I spent 40 minutes with this patient, more than 50% of the time was spent discussing the care and coordination of, you know, fitting and scleral lens treatment, and that we discussed all, you know, management and whatnot like that. And similar to Mindy, my billing specialist hasn't really contacted me saying that I was doing anything wrong, and so it might be okay. We'll find out. Um, and I think that's pretty much it for all of the questions for tonight. Feel free to email us if you guys have any more questions, and we're going to definitely post this webinar to our Scleral Lens Education Society YouTube page. And please sign up for our next webinar, which is basically another grand rounds, and they're going to talk about the fitting and management of the complex cornea, and that will be on October 26th, another Wednesday at 8:30 p.m. Eastern Time. Thank you, everybody. Thanks, Stephanie and Mindy.
Thank you, Karen. Thank you, Mindy, for all of that amazing information.
Thank you, everyone, and thank you for joining us this evening.
Good night.
Good night.